Okay. Now we just go. All right. So I'll be talking to you like over, 3 lectures about, whom in IV for chronic hypercapnic respiratory failure. So I will divide them into part 1, part 2, and part 3. So today we'll start with part 1, which is mainly chronic, hypercapnic respiratory failure due to COPD and how, or what's the evidence to, pursue whom in IV for that. Lecture number 2 will be about obesity, hypoventilation, just only the respiratory failure aspect of it, and some, muscle weakness and restrictive, lung diseases. And the third lecture will be how to write the prescription for whom in IV for various, respiratory problems. I don't have any conflict of interest to introduce about this topic. So the presentation layout will be to, kind of educate you somewhat. I'm sure that you all know this, but it's just to put it all in the, one context about the nocturnal NIV, the importance for that in COPD, and what kind of evidence we have to support it. And we'll touch base about obesity, the overlap, COPD, and obstructive sleep apnea, and how, to tackle all the challenges that we have from, CMS and stuff like that in order to get our patient on the right treatment that they deserve. I will start off this lecture with a case. So a 68-year-old former smoker, female former smoker with 60 back-year history of smoking and severe COPD, FEV1 27%, on home oxygen, comes for COPD follow-up. So the patient has history of dyspnea and exertion with mild to moderate activities, fatigue, morning headache, excessive daytime sleepiness, sleep interruptions, and some mild leg swelling. Last exacerbation was 12 months ago, and the patient finished pulmonary rehab. No significant emphysema on chest imaging. She had a PSG that was done, and there's no evidence of sleep disorder breathing. And her echo was normal with no evidence of PH. And this is her ABG. Okay, so before I get to the next part of this case, so if the Ramsha, if the patient has no evidence of sleep apnea from what you can tell on the PSG, so what can explain the, fatigue, morning headache, some excessive daytime sleepiness, sleep interruptions? Because whenever you see these symptoms, they are non-specific, okay? And the first thing that comes to your mind is the sleep disorder breathing. But we screen this patient, there's no sleep apnea. Or at least what other condition that should be thinking of that might explain these non-specific symptoms? Chest.
Hypertension, she has no signs of pulmonary hypertension. Fatigue, headaches.
Especially like the morning headache, interrupted sleep.
Any other sleep,
dyspnea at night.
Sleep apnea, any other sleep disorder.
That happens at night, right?
Right.
So whenever you see this, so those are non-specific signs of, chronic respiratory failure. So if you have, some worsening, some hypercapnia at night. So when they wake up in the morning, they have morning headache. People, they report some excessive daytime sleepiness, even if they don't have, sleep apnea, some sleep interruption. It's all about the, hypercapnia that got worse at night, okay? So these non-specific symptoms, we ask all of our patients about these symptoms, if you think, when you see them on the, when they are stable in the clinic, to see if their chronic hypercapnic respiratory failure is symptomatic. All right, so patient is optimized on medications, vaccination, everything, and they're asking, what can you do to improve survival and quality of life? So it looks like this patient is optimized for everything, right? So the two things that we have from what you know is lung, or is ongoing, supplemental oxygen for severe resting hypoxemia and smoking cessations. So those by far is the evidence base that we have for COPD patient that improves survival. So, and then that brings the question: does the long-term nocturnal NIV improves survival in COPD patients? So we'll know the answer as we go during this presentation. So this brings the question of why long-term NIV, in COPD to begin with, okay? So before I get into that, I think I'm just bringing this, I'm not going to talk about the acute need for NIV for COPD, but the people who got interested in kind of determining whether long-term NIV at home for COPD is going to be beneficial. So people, they started to get excited about it after the results that we have about the acute short-term NIV for COPD. And as you can see, these or this actually slide kind of at the bottom, as you see, number needed to treat is 8 to prevent death, and to decrease, or to prevent intubation is 5. So it is very quite unique in medicine where you see like the number needed to treat is just single digit. So it is a standard of care. This is why by default, everyone in the hospital, even the medical students, they know that if someone comes to the hospital with COPD flare-up, they need to be on NIV acutely. And then the question was, and the notion was, okay, if it helps, and as you see, it's a grade 1. So, I mean, it's a quality improvements. If you don't do it, you might be sued for someone with COPD. So if, it helps people in the acute setting, how about we discharge them on it? Or how about we continue to treat this hypercapnia? Because this hypercapnia, everyone thought that it's something, really, dangerous on the long run. So after a COPD flare-up, so the post, acute COPD exacerbation hypercapnia was linked to increased mortality. And as you see, it's a U-shaped. You can argue even when the CO2 is on the low side, like on the 22, or if it's higher, like in, 60s and above. So this is linked to increased mortality. So even after they get, over their COPD exacerbation, they're still at increased risk of mortality. So in order for us to understand how the NIV is going to help us with COPD patients, we have to understand what happens when we sleep. So what I have here, the 3 main components, and that can happen to each one of us, okay, even normal individuals. So even you, of course, you had those 3 last night. Ventilator control problems or instability at night, upper airway function, there will be changes in that, changes in your ventilatory control and your lung volume. But Dr. Magri didn't get affected last night because he doesn't smoke, right? Okay, so this is what happens. So when we sleep at night, the first thing, think about it, your brain, okay? Your brain, so your central chemoreceptors, so especially for CO2, the sensitivity drops 20 to 50%, okay? For both hypoxic and hypercapnic drive. When we sleep, we lose the ventilatory control or the effect of the cerebral cortex on the brainstem breathing centers. So brain doesn't work well when we sleep. So decrease chemo and hypoxic and hypercapnic respiratory drive. When we sleep, also the upper airway will have increased. This is why people, they snore at night and the sleep disorder breathing becomes more manifested. And that will be translated in more, increased work of breathing and less and inefficient ventilation, because the patient has to overcome the obstruction in order to, ventilate. Your FRC will go down, when you sleep at night, diaphragm pushes up, FRC goes down, your tidal volume goes down, everything goes down. The only thing that I want you to remember that is your respiratory rate. So when you sleep, it does not go down. It's either stays where it is, which is in some instances is abnormal. So it either stays normal or it increases because your tidal volume goes down and you have shallow breathing and your minute ventilation will still go down. But what helps on the other side is that when we sleep, our metabolic rate goes down. So that helps to some extent. But the bottom line, even in normal individuals, bottom line, you will have less minute ventilation. But why it's not clinically relevant? Because if you see, even in normal patients, as you see here, like your CO2 will increase by 2 to 8, your, PO2, 3 to 10. and you will desaturate at night. So, the next is when you have sleep apnea. So when we are normal, so we live in that flat curve of the, hemoglobin, oxygen hemoglobin dissociation curve, okay? So even if you drop, your, SAT is not gonna drop that much. But COPD patients, they live in that, slope curve. So even if you desat a little bit, so like if your PO2 goes down by 10, so that will result in significant desaturation. So this is why normal people, they don't get affected by all these three components when we sleep, but the manifestation of this will be quite significant in sleep apnea. So this might appear to be complicated, but I want you just to focus on what you see in that yellow box. We think that home NIV for COPD, it helps only if it causes complete or near complete unloading of respiratory muscles, okay? So this is why using sometimes conventional low kind of pressure, it doesn't help to wash out the CO2 and induce some kind of respiratory rest. So what you need to do is that these muscles, they are quite fatigued people, they have, quite hyperventilation or hyperinflation, and they have a flat diaphragm. So, and the diaphragm becomes inefficient, okay? So what we need to do at night is to completely take care of the work of breathing and ventilate the patient, wash out the CO2. So these respiratory muscles, they will get more rest. So they will become more efficient during the day, where at least the dynamic hyperinflation will be less, the FRC will be better, at least when they are awake. So only if the nocturnal ventilation at night achieves some kind of, unloading of respiratory muscles, that's what was shown in the studies to be associated with some improvement. Okay, it's not just only put someone on CPAP or BiPAP. It only helps if it achieves this kind of target. Any questions so far? All right, quick. This study, this is what I told you. If you focus on this, when they tried to test this hypothesis after they saw the success that we have with the acute NIV for COPD, they tried to use the conventional, CPAP, BiPAP, or BiPAP settings that we use, 12/5, 14/2, whatever. So in multiple studies, these studies were negative. Okay, why negative? Because if you look at the second column, which is the CO2, it probably didn't change because you did not use significant, pressure support to wash out the CO2. This is why the first few studies, though, they were kind of disappointing. And then they came up with this, proof of concept study, high intensity NIV. High intensity, if you look here, high intensity, this is what it means. Your IBAB somewhere close to 30. This is the average, okay? So it's 28 plus minus 5, and your EBAB is, around 5. And why it's around 5? Because in these studies, especially the initial studies, they didn't include sleep apnea patients. And 4 is the default. You can go below that, right? So in these studies, they proved that, as you see here, the CO2 is statistically significant. They will be able to drop the CO2 for the first time. And then the challenge became, well, high intensity, it might help us to decrease the CO2 and hence maybe improve the clinical outcomes. But is the patient going to tolerate that? Is going to be mask leak? Is it going to be working on the, clinical, side of it? So there were like multiple studies that looked into this, and to everyone's surprise, like especially like in this study, they saw that the patients who actually were placed in high intensity NIV, they wore the mask and the machine for 3.6 hours more than what the people in the low intensity group did, because this is a crossover. People, they started on the side and then switched to the other side. Okay, so the compliance wasn't an issue, and they linked this because people who actually were placed on the high intensity, they saw improvement in their dyspnea, their quality of life. So that motivated them more to wear this. So this is why this, kind of, eliminated this, concern that, high intensity can be tolerated by patients. Of course, the leak was high, but it didn't affect the clinical outcomes and even the sleep part of it. So the distribution of their sleep stages, it was basically the same. So this is why the high intensity NIV was getting more, popular. So this slide here, so I want you to focus on the bottom part of it, because I said near complete, unloading of respiratory muscles. So with the spontaneous breathing, so they dropped, this is an Italian study where they, studied, I think around 40 50 patients, I can't remember right now, but they have like a esophageal balloon where, measures your esophageal pressures. So, so the first column is when you have, when you're spontaneously breathing. Second, when you're low intensity. And the third one is when you have, the high intensity. And as you see here, so people, they are working to breathe, and then they're working less if they are on, low intensity. And if you have them on high intensity, so that's completely takes over the work of breathing, okay? And this is what it does. So this is by far, this study is the most important study that I'm going to present to you. So I only chose 3, clinical trials, because you will see like people that are publishing all kind of meta-analysis retrospective, and it gets more confusing. So I decided to just decide on the main bulk of evidence and the most 3 randomized control studies, and they were done in Europe and none that was done here in the US. So this is the German, or what we refer to as the Conline study. So this study showed mortality benefit, and as you see the graph here, so the 2 graphs are clearly and drastically different. So you see clearly the mortality benefit. But I just want you to pay attention to their inclusion criteria and the study characteristics, because if we want to translate this into the clinical ground, we have to see what kind of patients they cherry picked and how it worked. Okay, so first, they did not include sleep apnea patients, so we don't know what to do with them. So PMI is almost normal, right? So severe COPD, so it's not just presumed COPD. So they have significant, or severe airway obstruction, and they have some hypercapnia. This is why the cutoff of 52, as you see in the CMS, criteria. And they use high intensity pressures, as you see. So this is the mean IBAP is 21/4. So at least the mean, pressure support will be around 15, along with backup rate. And the reason this is not PIBAB in a spontaneous mode, because we have 2 parts, spontaneous and PIBAB is the spontaneous time. Like if your, minute ventilation drops, or your, respiratory rate drops, at least it will guarantee certain minute ventilation. So if you want to, this is what they are doing. And as I will show you before, so this is completely different from what the CMS wants you to do. So this is why we do the zigzag weight in order to get them, the machine, if you want to do that. So, and as you see clearly, it was associated with survival benefit. But remember here that they will be able to decrease the CO2 to less than 48, or 20% from its original value, because if people, they live at 90, 70, it's not plausible to bring it to less than 48. But people who responded and had mortality benefit are the ones who had the significant drop in their CO2, as it was explained here. And then everyone was excited after the study, and then that brought the question is, can we start early? Because these people, if you see, they actually got started after 4 weeks or even more, okay? I tried to look all the supplements, but I mean, it's very conflicting, but definitely it is 4 weeks or more, okay? After the, the initiation of NIV. So they are not in the middle of having exacerbation. They are chronic, severe COPD who are stable, okay? But they have hypercapnia. So in this, Dutch study, so they started early. They admitted patients for COPD, severe COPD, and they started 48 hours after the termination of acute NIV support. Someone comes, get treated for COPD, and then once their pH improves, they switch them to the intervention group, especially if they want to participate in this study. So again, they use the same thing, BiBAB, high intensity in IV. And this study and the other study, by the way, I forgot to tell you about the German studies. They admitted them to acclimatize them for the high intensity pressure support. So it's not like a send home device. No, they admitted him for on average 4 to 5 days, just chilling there and using this machine at night, during the day for a few hours, and then mainly at night. And they got discharged after 4 to 5 days, just to go home with this machine. But they weren't admitted for COPD flare-up. These people, they were admitted and they were kept after their COPD flare-up actually improved. And to actually, everyone is surprised, there was, no significant mortality benefit. And I think in order to know this, if you concentrate here on this graph, so there is what we call treatment dilution effect, because 26% of the study population, they were eucapnic at 3 months. So that means even people in the placebo group or the not the experimental group, they got their CO2 almost after 3 months to a level that was comparable with the experiment group. That tells you that when you are close to your exacerbation, you might have hypercapnia that will spontaneously resolve. So maybe one of the explanations that this study didn't show mortality benefit because they started early and they included patients who should not have been included because they don't have chronic hypercapnia. So this is why doing it in the hospital when they come here is not something that will change outcome. And we'll come to that scenario later, but this is why we don't start early. So I think this is very, interesting study, and this will be the third one and the final one. This is a UK study, severe hypercapnic respiratory failure, okay, as you see. And these people, the only thing that I can tell you to, think about it, these are end-stage COPD. And if you see in the, green box, those are the kind of patients that we struggle with in clinic and also in the hospital because we have nothing to offer them. So if everyone almost nothing, and they are hypoxic, so all the study population here, whether they are in the, intervention group or in the control group, they are hypoxic at rest. So they are requiring oxygen, advanced COPD, and they're included patients with, CO2 of at least 53 or more. And here they didn't start that late, but they didn't start after the exacerbation. So they started to include patients 2 to 4 weeks after the resolution of the COPD flare up. And the definition for that will be pH at least more than 7.30 with some kind of clinical stability. So they screened the COPD exacerbation patients, and then they met them 2 to 4 months, 2 to 4 weeks, and then they repeated the ABG, and they decided who actually should get enrolled into the study. And again, they admitted these patients. So in the German, Dutch, and British actually trials, they admitted these patients to get them, acclimatized and get them, titrated on the high intensity NIV. And again, this study also didn't include sleep apnea patients, so the average PMI is 32. So if you have end-stage COPD on oxygen, they have tried very much everything and they're still symptomatic, this is the way to go. So when they actually looked into the difference between just only standard of care COPD plus home oxygen or standard of care plus home oxygen plus home NIV, and they looked into the mortality at 12 months, it was not different, okay? But so when you see here the intervention group and the experimenter and the control group, so there was almost 90-day difference between the two groups when it comes who got admitted or who got like the composite event. The composite event here is any admission or death within the first 12 months. So the control group that didn't get the home NIV, so the average they got admitted in about 1 to 0.4 months from the discharge, because these are in the stage COPD. And people who got the home NIV, they still got admitted within 12 months, but it happened at about 4.3. Okay, so if you look at that from a quality perspective, and like the bounce back and the insurance admissions, because if you get someone admitted to your facility within 1 month or so, you may not even get paid. So with this strategy, at least you're delaying the readmissions. So we still don't know. They're still working on this study, and there's data they are collecting now, the difference after 3 years and 5 years. They have not published that, but at least at 12 months, there was no difference in mortality. But there is improvement in quality of life and decrease in the rate of readmission from COPD. Because I want you just to take this as a positive point, because you're talking about people with no hope. Like end-stage COPD, they're coming every couple of weeks to get admitted. For them, that might be something different. So bottom line for these trials, so we only should use it in chronic severe stable hypercapnia. We don't know exactly if this will work for patients when they have the combined COPD and sleep apnea. And all these trials, actually, they admitted patients. So trying to initiate the home NIV at home, we still don't have a great data about that, because these trials, they were done for patients when they were admitted just to initiate the home NIV. So this is an important paper if you guys want to read it, but I will just give you the summary. This is the ATS, I think 2020 recommendations regarding the home NIV for COPD. So who to select? So this is how we apply to our patients. COPD, at least they have resting PaCO2 of 52. The ATS paper, they're saying 45, but at least as of now, I don't think that it's something that we can do, because most of the insurance, they will not pay for, a PCO2 of 45. Plus, there's no, evidence to back it up, honestly. It's all like low quality evidence trials. We still need to stick by the 52. So also, I want you to make sure that you should do your due diligence to make sure that you have the diagnosis right, because sometimes it's obesity, hypoventilation, something else, heart failure. So we tend to lump everything under the umbrella of COPD. So the 2020, as I said, ATS guidelines. So this is their recommendation for the 45. It's low quality evidence. So bottom line, COPD with some hypercapnia, and they are not in exacerbation, and they are stable if you want to include them. And this is what they mean by the stability. At least they are 2 to 4 weeks after the resolution of the flare up and the acute need for an IV. You repeat the ABG and check if they are hypercapnic and they meet the other criteria. You can proceed with the home NIV. And again, so I say optimum timing, we still don't know. And even, the data that we have is very limited, but at least we can go with 2 to 4 weeks, okay? Because right now, we still don't have a great tool that can tell us whose hypercapnia is going to resolve. There's no clinical predictors, okay? At the bedside, when you see someone, I see this question a lot. Okay, this patient has CO2 of 80. Do you think that even if you wait 4 weeks, it's gonna go down? Maybe not, okay? But we still don't have great, tools that we can apply at the baseline, at the bedside, that if someone comes even with CO2 of 65, that, okay, this person, even if I wait for 4 weeks, his CO2 is not going to be less than 52. So let's start now. We still don't have that kind of information, unless maybe, as I said, you're dealing with someone who lives in the 80s, 90s, maybe you can win that argument. So this is case number 2. 65, former smoker with 40 back year history of smoking, severe COPD, FEV1 33% predicted, on home oxygen, who comes for acute and chronic respiratory failure secondary to COPD flare-up, was admitted to step down, and acute NIV was initiated. This patient had 4 admissions in the last 10 months, okay? And 2 of them requiring intubation and mechanical ventilation. So it's different from the other one that you're seeing in the clinic. So this is the patient's BMI, no history of sleep apnea or heart failure. On day 6, patient got better, and the patient required the, BiPAP or AVAPs, whatever you want to call it, on and off for 4 days. And this is the ABG on day 6, 7.39, 61, and 68. So would you start the NIV? Yunus? You want to start on this patient? I think I will agree with you. How about the other people?
Yes.
Dr. Maggie, you want to start?
No, I said, like, why would you start?
What's that?
Frequent exacerbation within the last 10
To be honest with you, like, if you're gonna follow the 2020 recommendation, yes, like a patient requiring mechanical ventilation, you might end up in starting him before even going out from the hospital. But many of our patients, we didn't go back and see why he was intubated, why he was in recurrent admission. Is it mainly the COPD exacerbation, and who was in pneumonia, he was in something else? So it depends on what was the prior admissions, and then I will decide if there's a
because you want to make sure that this is first of all, patient meets the criteria for at least for even the presumed or confirmed COPD, and they have exacerbation, not PE or something else.
That's right. If
Okay,
that's for
perfect.
sure, if that's for sure, and the patient have like a no, like a and like if it's not for sure, I mean, and the patient, then I will give him the 2 weeks and see, and I will see what's the recurrent. Like he admitted 4 times. Is it every 2 weeks? Can I have some time to send the patient home and look at his ABG in 2 weeks, or he's usually like coming to the hospital in 2 to 4 weeks? That's a thing that I look at. If it's not, okay. Yes.
I agree with you 100%. So
I
it's
was gonna, can I
individualized.
make a comment? I was gonna make a, this is Dr. Taviano at the VA
Yes.
hospital. What I've seen in these, a lot of times when they come in, because I see that a lot of times once they're hypercapnic, they tend to say, oh, it's always due to COPD. What I found acute on chronic, usually it's more than one thing driving that PCO2 up. And I think that's why in your lecture you alluded to being very stable PCO2 elevated, because when you have acute on chronic, some of these patients can come in with a fast heart rate going in and out of atrial fib, and they go into
Pulmonary edema and stuff.
CHF, and if you look at the x-ray, it might not be full pulmonary edema, but if they have just some mild edema and you're not looking at the x-ray close, it's enough to make that PCO2 go up. So I'm just saying, a lot of times we blame it when someone keeps coming in exacerbated. The first thing I say is, it all due to the COPD, or am I missing some other stuff such as ischemia, CHF, for
Correct.
whatever reason, atrial fib, paroxysmal atrial fib, that can fool you. So a lot of times the ones that get readmitted, yeah, it can just be COPD, but what I see is that where the mistake is everybody saying, oh, it's COPD exacerbation, when in reality there's some other hypothyroid could cause, problems too.
Correct.
Anyway, that's
So,
my point.
Yeah, I mean, I agree with you. So if we, so my point here in the question is that, if you, looked into all these issues and you actually were be able to confidently say that these are frequent COPD exacerbations without any other confounding, factors. So I think what they have in the guidelines, also in the ATS guidelines, is that if you are successful to wean your patients off the NIV, by the way, the acute NIV, sometimes you will have people where they can stay in the hospital for days when you stop the, daytime and the nighttime, especially like the nighttime, NIV. So the next morning they'll become slightly altered. Maybe their pH is dipping off, their CO2 is going up. So if you are able to wean off your patient safely off the NIV and they don't have very frequent exacerbations that are serious, to the point where they need admission to the step down and ICU and everything like that, you don't have to start the NIV early. But they left it as individualized decision. If you have someone who is having frequent exacerbations, provided, as you said, this is all COPD and it's not due to something else, which is not what we see in real life, because you can count on hands where you can encounter this situation per se, where it's mainly COPD. But if you can't wean off your patient while they're in the hospital being treated for COPD exacerbation, you can proceed with, especially if it takes a long time. And at that time, I think it will open questions for you why you can't wean them off. Is there any maybe myocardial ischemia, congestive heart failure that's contributing to this? But if you do your due diligence and the only thing that you can think of is the COPD, then you can start. So they have it as individualized, but we should strive not to start the NIV, the home NIV for COPD when they come to the hospital. Because at least in the British trial, around 30% of what they screened in the hospital, they did not qualify. Okay, I can show you this. So they did not, yes. So in hot HMV's trial, which is the British trial, so what you see here, 21%. Yeah, they did not, they were excluded. Why? Because their CO2 was less than 53. And the Dutch one, yes. And this is what, 26, almost a quarter of your patients, they will not qualify. This is why we have to wait for 2 to 4 weeks. Okay. All right. So next step will be location. So it's still challenging in Europe. In these trials, they were admitted. And by the way, their system there, they allows them for reimbursement to admit patients to get them acclimatized to the high intensity NIV, but in the US, it's not something that we can do. So you can wonder, start them in the hospital, send them, with it, or maybe bring them to the sleep lab, or just send them like a, AVAPS machine or something that you can initiate safely at home in order to do the job. So we still have, positive data about this. A algorithm that we can go by in order to titrate these patients. We have, protocols for sleep apnea, central sleep apnea, stuff like that. But for COPD, COPD patients, to bring them to the sleep lab in order to decide which pressure that works for them, we still don't have that protocol yet here, okay? And again, it will also delay the treatment. So what I think, based on the data that I looked at, is that it is safe to start home, okay, to initiate the NIV even at home. And when they looked into this proof of concept study, I think from Netherlands, so they looked into the home initiation versus the hospital initiation of NIV, and they used either BiPAP spontaneous timed or AVAPS. So as you can see, from what you can see here, so both the people who got started with the NIV at home and also in the hospital, they had significant, decline in their PCO2. So it was working at, 3 months and 6 months, but the significant difference, almost half of the cost, okay, when it comes to, admitting them to the hospital and starting them. So based on this, we cannot, make recommendations, but here in our system, this is the only thing that we have, is just to start them at home, or maybe, start them in the hospital if you want to do that, especially if you can't wean them off or something, and send them home with it, because those are the only, few options that we have, and they're still working right now to do some trials in order to see how is it going to, work here in the US, either to do the home initiation or the sleep lab. It's still, a focus of multiple studies. So what kind of mode that we use? I think I reiterated this multiple times. It's not the conventional BiPAP. We have to guarantee some minute ventilation. We have to make the respiratory muscle to rest at night and to wash the CO2. People who actually had, all these criteria met are the ones who actually got some kind of improvement and some kind of mortality benefit from the German trial, as what I showed you, okay? So I will come back to these issues when it comes to how to prescribe the home NIV in the third lecture, okay? But usually we start with, EBAB or PBO5, which is, the minimum that we can start, and some backup rate, which is just 2 to 3 breaths less than the, normal, spontaneous breathing rate, and the exhaled, tidal tidal volume of 8 ml per kg ideal body weight, okay? So we use this mode a lot, the volume assured pressure support. And again, I'll talk about this in details in the third lecture. So it is one of the convenient things that we have, and we can start it in the outpatient settings. So at least as of now, based on the data that we have, and it's all coming from retrospective trials, by the way. So VAPS is not inferior to high intensity pressure support spontaneous time, because all the European trials, they use the high intensity BiPAP spontaneous time. Why? Because they had admitted patients. So today or this hour, we'll try this pressure. Maybe if it doesn't work, and they have respiratory therapists who's staying with them. So, but for us, we don't have that. This is why we tend to, say that let's have this tidal volume and this minute ventilation, and please the AVAPs do that for me, and I will leave that to the discretion of the AVAPs to use a IBAB pressure of 10, 12, 30. You have an upper limit and lower limit. So this is why we do it. But the bottom line, we're trying by doing this to simulate what the European people they did in the trials. But we have to understand that kind of caveat.
So I don't know,
Sure.
So sometimes what I do is when I know like this patient has recurrent exacerbation, when I see him as an inpatient, I look at the BiPAP settings and what is the volume that he have done while he's in the hospital on that BiPAP settings. and was it sufficient enough to treat him? At least when I discharge this patient, if everything works right, and he will come back. to
Is
my
that
clinic.
you look at it every day, every night, or just only one time?
No, like usually when he's close to stopping the non-invasive ventilation, I look
Okay.
at his settings and how much volume. And then like when he comes back to me in my clinic and I check and his PCO2 is still high, I usually put him on those settings that he was on that I already saw in the hospital. That usually it worked with me, and like when I get like patient tolerating those settings well, which is high settings as he was in the hospital. Because I asked you at the beginning when I started the Practicality Challenges, like because at the beginning it was like tough for me to just start in BiPAP without knowing like
Yeah,
what
yeah,
the
because it's not you're not chasing sleep apnea or
That's
anything
right.
like that.
And then you don't like just start AVAP, and it was like that was my to go.
It is something that you can do. I think for now we don't have a great evidence.
Yeah.
Okay. So if you think that this patient close to their discharge, this is the settings that actually work for them, and you looked at their breathing rate and stuff like that.
That's
So as long as you're able to prescribe them the BiPAP ST, not just the conventional
Yes, yes,
BiPAP, I think it will be fine, but you will still need to see them in the clinic, look at their download and see how much, minute ventilation, tidal volume that they are generating with that. Because even with the AVAPs, by the way, it's not like the AVAPs doesn't make mistakes that if I tell the machine to give this patient tidal volume of 500, that means it's 500. So when you see them in the download, you have to look at how much they're making. Maybe they have leak, maybe in the hospital they were like on the dry side, now they have heart failure, so you need to increase the pressure, stuff like that. Your approach, it can be done, but you have to have a close follow-up, repeat the ABG, assess the symptoms. But as of now, we can use the AVAPs. It's not inferior to, but the clinical trials, the big ones that I told you, it's not AVAPs. It's BiPAP ST. Why? Because they have the resources. So we have the evidence of BiPAP ST high intensity, stable COPD, not an exacerbation. I hope that you didn't lose this because it's very important for you to understand this concept. And you asked me why we're not qualifying this patient, right, Ramsha, when we were working last week. So now you know the answer, right?
So you say high intensity, put him like the study 28 plus minus 5.
High intensity, based on the studies, minimum at least 15 pressure support. 15, at least the minimum. The difference between your EBAP and your IBAP.
So I know on consoles at Cabell, there's like a really big push to have like everyone, if you do qualify them, they go with AVAPs. I like nobody's
Well,
going with BiPAP.
I'll explain that to you because unfortunately they just made it. Don't get me started on this. We'll come to this point. All right. By the way, they pay more money for the AVAPs than for the ST, but it's for unique people, this ST. Okay, so COPD, sleep apnea overlap. So this is what you saw like in the picture. So people, they have COPD and coexisting with coexisting with COPD, and this is what the overlap means. And you will see sometimes people, they use this for COPD and asthma. So it's very kind of vague term. So it depends on the clinical context. So what to do with these people? So the guidelines from the ATS, it was all over the place. So it's low, certainty and condition recommendation that we need to screen sleep for, obstructive sleep apnea for COPD patients. So especially like if I think it wouldn't hurt, but it shouldn't delay your treatment. You can do that. You can use, like the, stop bang scale or whatever. So, the Epworth sleep scale, it was not validated for, COPD population. So if you want to use, you can use the stop bang. But how to, and those are the, kind of, symptoms and signs that if you see, I think it becomes a mandate that you screen for sleep apnea. You can start your treatment. If you are in a hurry, you want to start them like on home and IV for COPD, you can do that. And I'll tell you what exactly the mode that you need to do. But in the meantime, you need to figure out, their sleep apnea component, because in these studies, the one that I presented to you, they were using by default PEEP of 5 because there's no sleep apnea. But if you want to use like what Dr. Megri is saying, like, okay, BiPAP ST, and then maybe he can decide about the IBAP, but the EBAP, it will be, something that you have to carefully select in order to overcome your resistance. Because if you have sleep apnea that you're not treating, it doesn't matter how much IBEEP you give, your ventilation is going to be, compromised because you're not, giving enough beep to overcome the upper airway resistance. So if you see someone who's obese with pulmonary hypertension, they have some symptoms, the one that I told you, the non-specific symptoms, you can screen them for sleep apnea. And why it's important, so I just want you to look at the Spanish study. So this is from 2010. So even CPAP alone can make the difference. Okay, so this is why don't underestimate sleep apnea when you see your COPD patients. So if you see here, so what they did in the study, so almost like in each arm, they have somewhere close to 2,200. So they looked into sleep apnea patients. So first they, screened who has the just only the, the COPD, and then they have the sleep apnea and COPD. And they offered the, based on the guidelines in 2010, so some patients, they may not qualify for, sleep so for CPAP, because if they have mild symptoms and, very low comorbidities, like, no hypertension, no diabetes, stuff like that, or if the patient, willingly deny or declined the CPAP treatment. As you see here in the curve, so the bottom curve is you have the overlap and people who either actually did not qualify for, CPAP, or they refused the CPAP. Look at their mortality rate. It's worse. And if you compare that to the COPD alone without sleep apnea, or COPD with sleep apnea but treated with CPAP, so that these two curves are very comparable. So that means the CPAP alone is able to bring the mortality down. Because if you have sleep apnea patients, COPD patients who is known to have sleep apnea, but the patient decided not to have that treated, thinking that he snores, but no one actually is getting, annoyed by his snoring, and it doesn't matter, I don't have symptoms. You need to educate them that their mortality is going to be, higher, because that there is a sleep apnea component that we are not treating. So it's very important here. What we can do for the overlap, so what I have here for you, if you know that they have sleep apnea, I think you can treat them for sleep apnea and see what happens, okay? Either with, CPAP or BiPAP, depending on what your, titration trial is gonna tell you. Again, we still have multiple clinical trials, prospective trials on the overlap syndrome, but we still don't have data. If you think your patient have what I say here, like OSA predominant. So they don't have like mainly severe hypercapnia. They don't have like morning headache. They don't behave that they have more non-specific symptoms that are stemming from the chronic hypercapnia. Then you can treat them as COPD. But if the main issue is that they are in and out of the hospital because of COPD flare-ups and their COPD component is, affecting their life, then you can treat them as, you can prescribe them the home NIV for COPD. So the options that you have, either to use, like BiPAP-ST, either to use AVAPs. And what I have here highlighted in red, and I'll go over this in details in the third lecture, AVAPs AE, which is O2 titrating. Because sometimes unfortunately in Europe, they have this device on its own, so you don't have to have home mechanical ventilator for this. But in the US, this mode does not, I just knew this when I was preparing for this topic. This AVAPs AE does not exist in just the respiratory assist device. You have to have a home vent for this. It's an add-on feature. They can simply have it, but for whatever reason, they don't as of now. So the beauty of this, so you can have the AVAPs, and you don't have to worry about the beep, even if they have sleep apnea and they're obese. Just tell this machine to, what did you say?
I thought the AVAP that we have, the outside, like when you order for AVAP as an outpatient, you can give the ranges of the AVAP.
But he's saying,
But it
you have
doesn't
to have
have out.
no, but you have to have a trilogy machine to be able to do the setting.
Correct.
There are regular BiPAPs that has this without a home vent. That's what he's saying.
Oh,
Correct.
Gotcha.
Because the trilogy, it's still a home vent, and the end is
So
very
we have
expensive.
to use the machines that
Correct.
without the home.
Yeah,
Wow.
in Europe, you don't, if you want AVAPs or AVAPs E, you don't have to have a trilogy machine for that. Okay.
Just like
Yeah, there is a respiratory assist device. They're, they can work, like they can give you CPAP, they can give you BiPAP, they can give you, but the other one, trilogy, it has like the vent that we have, 10, 15 modes that, you can choose from.
And even here in the States, there is a VAPS only device. It's just that here, for example, West Virginia, they just don't bring it. They have trilogy only, but
Maybe.
there is a, I used to,
Yeah. The one that I'm talking, Muhammad, is the AE one.
Just as AVAPs.
Yeah,
And
the
also everything below.
ABAP, EE, AE.
Not AE.
It's
That-
not in the state, is that right?
Yeah, you have to have a trilogy or home vent for that. So the beauty of this, you can have a sleep apnea, obese. You don't know exactly because you don't want to guess like 5, 6, 10, 15, 20. Just tell this machine, I need the EBAB to be in range from 5 to 20, and the machine will figure it out. So this is if you're stuck until you do the sleep apnea test and figure out how much PEEP exactly they need. So the practical challenges, hopefully, I think we have a couple of minutes. You asked me this question, Katie, right? So this is the CMS data. And by the way, these are from 1998. Right? And the German study, is it in 2004 or 2014? And you have 2016, and then the British one, 2017. There's a lot of trials.
I have
And
the
the-
guideline for the year 2020, and they don't want to change it.
Correct. So they have now, there is a 3 papers from CHEST. So group, they call that technical expert panel, group of people from American Academy of Sleep Medicine, ATS and CHEST. So they are writing a proposal to the, national, they call that qualification determinant, and for the CMS also payers to adopt the new guidelines, and they are very fantastic if they get accepted. I think they submitted them last year, and the papers are from November of last year. So as of now, we still actually are abiding by what we have here. So if you want to apply this, so it's very rigorous criteria. So you have to be, hypercapnic. Okay, we don't have any problem in the first requirement. Second requirement, so they want you to, first be on oxygen and at least 2 liters or even more, depending on if you are prescribed higher than 2. And they want you to show that you're still hypoxic. Okay. So if you read this, so that means maybe we can fix everything with oxygen, right? So this is the way that they are, proposing all of this. And you have to make sure that you don't have sleep apnea or sleep apnea that can explain this, and you don't have to have a test for this. So they are flexible on the third one, but I think the second one does not make any sense, and the reason is this. So because in the expert panel, they said there is 0 evidence to have the second component where they want you to be on oxygen first before they can get you qualified for something else. So when you look at this study here, so even when you have hospitalized COPD patients receiving 2 liters of oxygen at night, so yes, you're keeping their SAT where you want it to be close to 100, but look at their CO2, which is, by the way, it's VBG, not ABG, but anyway, it will be still higher. So prescribing oxygen at night doesn't solve your ventilation problem. So why they have it? 0 evidence. Big 0 evidence. I'm really serious, okay? So I'll tell you how we get our patient prescribed if we want. So first they want you to, and even if you meet all of this, by the way, they will give you the BiPAP only, no BiPAP ST. So that means if you're apneic, you're apneic. So it's not, there is no backup rate. The backup rate is what makes this device expensive. Okay, so you have to try that first. So I'm not going to read all of this because you guys can read it. So they want you to try it and to come from like after 61 days, and you have to prove that you still have symptoms and your CO2 is still high on the regular BiPAP, and you still need to meet the oxygenation criteria. So I think if we go with all of this, maybe in a span of 10 years, you can count 2 or 3 patients who actually can get qualified for BiPAP. So what we do, and actually we have the right to say this sometimes because we see the complicated patient in the hospital and they have very bad hypercapnic respiratory failure. And we try them on BiPAP and stuff initially when they come and they don't get better. So they need some form of either AVAPs or BiPAP ST. AVAPs or BiPAP ST when you go, so there is a minute ventilation guaranteed. Okay, you're helping your patient. It looks like you're intubating them, but you're not putting a tube, just a mask. And they can go south anyway, right? So we prove, and this is what we write in the note, patients tried BiPAP failed, required, AVAPs or BiPAP ST for advanced support because of worsening hypercapnia symptoms, stuff like that. So this is what it gets them approved. And by the way, if you see here, this is the problem now that they're trying to solve. And I will conclude with this. You see 2009, 2015, right? So pay attention to the pie charts in 2009. What you see, colored in blue is the indication of home vent, okay, in 2009. Forget about the other half of the slide. So people, they get qualified for home oxygen. Why? Because for home vent, because they have neuromuscular disease, which is very legit, right? So if you see like this COPD part of it is, you know, around 29, something like that. Look at what happened in 2015. COPD predominates here, right? So people, they get prescribed home vent just only to get the NIV component at home. Why? Because they just made the other criteria. Either you have to meet the oxygenation. It doesn't make sense. So this is why we jump directly to trilogy. We don't need every single mode that the home vent can provide your patients. But because of the insurance issues that we have, people, they find it is much easier to get this way. And by the way, no one is happy about this because, you know, there's a lot of, you know, money that's been spent for nothing, because these people, they still function well. They're not like, you know, Duchenne muscle dystrophy and stuff like that, where you need to provide them sometimes not just only one vent, two. What if the other one, especially if they get dependent, they have a trach and stuff like that? This is sad, but this is the way that they have the, you know, compensation and the insurance and the CMS criteria. So this is why people, they are trying to get their patients qualified through the statement that I told you, documentation that they didn't do better. This is, you see how actually it got worse, or how the COPD kind of, you know, became the most common cause for home vent prescriptions. So this is what's happening in the US. So practicality challenges here. I think I'll come to address all of that in the third part when it comes to how to prescribe. But the point that I want you to get out of here: severe, stable COPD are the kind of patients where you need to prescribe in this. If you have someone who's been admitted, but you can't wean them off in the hospital, it took them a long time, I think it's okay. That clinical vignette that I presented, where someone comes in and out of the hospital with, you know, where it appears that it's mainly the COPD that's driving the respiratory failure exacerbations and not something else, I think you can proceed. But short of that, there is no evidence to support, you know, prescribing, because here our hospitalists, everyone who comes with COPD, even if their CO2 is 44, they want you to get them a machine and for qualification. AVAPS qualification. Sometimes the whole service will be AVAPS qualification service, because this is the only consult that we get. So this is why I chose this topic and the grand round, at least to tell them that it's not like a standard of care, because the other one, people, they can show you. If someone comes with COPD flare-up in the hospital and he stayed for 24 hours until he gets intubated and no one tried the BiPAP, that's a lawsuit, because it's a level 1 evidence. But you have someone with COPD, CO2 of 60s, okay, they can wait until we see them in the clinic. Okay, even if it's bad, even if it got, you know, this patient got intubated. So it's a conditional recommendation. So it's not like a high level or a quality improvement, you know, parameter. So you have to understand what is the difference. Okay, any questions? All right, guys.
And sometimes the concept we got is not really COPD bypass, it's more CO2 elevation. And not, so that's why if you guys see me, like, we spend a lot of time dissecting why the CO2 is elevated, because not all of it is COPD. And if you look at these studies, for you to start retaining CO2 because of COPD, purely because of COPD, you really have to have like very severe COPD, or if you want to do less than a liter. Mild COPDers will not have CO2 retention. So you'll always, when you guys run on me, you'll see me having a lot of resistance to giving patients non-invasive at home. I always want to repeat it again as a patient, especially if I believe there's a multifactorial component, right? You have patient with ARDS, COVID, intubated for 5 days, diarrhea, lactic,
AFib with RVR and ischemia.
Also, the retained CO2 exhibited non-invasive for respiratory, to prevent re-extubation, and now they're retaining CO2, and that's not COPD, and then you get that consult. So you'll see me, like, if at least I'm running, that we spend a lot of time looking into the reason why, and I usually have a lot of resistance to giving these patients non-invasive. I usually like to see them in outpatient for the reason that Dr. Drew just mentioned. And then obviously the studies, you can see that these studies can't be replicated in real life. I don't think they can be replicated in Europe. They can be replicated only in very well controlled studies. It's just, you know, they admit them to the hospital to find good pressures. We don't do that. I used to send my patients for sleep studies, and I realized that technicians don't really know how to titrate a BiPAP for
sleep apnea.
No, just for sleep apnea. They don't know how to titrate it for CO2 for COPD management. So I started not doing that. now I use the AVAPs most often, or if they're already on a machine, I check frequent ABGs, not even just tidal volumes, because again, you want to unload them. You don't know if you're unloading them or not because you don't have an esophageal monitor. So I check CO2s and maybe blindly make changes accordingly every few months, or an AVAPs machine. So it's difficult. That's why, and it's expensive. So I don't give it to everyone. You'll see, like, the studies are a small subset of patients with maybe 5%, 10% of our patients that we see in the hospital or in the clinic maybe meet the criteria for.
Correct. And yet it's still a common consult. You can't have a 1 week that can go, or even a day without having this.
Yeah.
So.
I agree with Dr. Justin. It's really important, guys, for you. Not every CO2 retention is COPD. You need to look it up. You need to see what's going on. You know what other reasons that led to high CO2. It's not just COPD.
So if you want to know some data about how crazy we are, assuming that, you know, everyone has COPD, if they have hypercapnia, you have to stay tuned until the next lecture. Okay. All right. So we'll go over so third part is the prescription part. Second part, we'll go over some other causes of hypercapnia and what is the indication for whom for the whom NIV. And the third lecture will be, okay, now you know if it's COPD, if it's sleep apnea, if it's, you know, obesity, hypoventilation, muscle weakness.